Hello, ladies and gentlemen. Welcome back to our series of lectures on anesthesiology. Today we're going to make a change in direction and talk about intensive care medicine, what intensive care is, the different types of intensive care, the qualifications of intensivists, whether they be nurses or doctors, and many of the conditions that are treated in the intensive care unit. We'll also talk about special drugs in the ICU and some special devices that are used in the ICU. So what is an intensive care unit? Well, it's a specialized unit in the hospital where the sickest patients are cared for. The physicians and staff in the ICU have special training to allow them to care for these very sick patients. There are drugs that are only used in the ICU and highly sophisticated pieces of equipment which assist in providing care. The majority of patients in the ICU will have more than one critical illnesses and more than one organ system. So it is extremely common in the ICU for patients to have multi-system organ disease. So how does anesthesia fit into all of this? Well, the operating room is often seen as an ICU, and anesthesiologists are often the primary physician in the ICU. Particularly in rural hospitals where there aren't a lot of subspecialty physicians, it's often the anesthesiologists who take on the care of the most critically ill patients in the ICU. There are different kinds of ICU. There's a general ICU which will handle pretty much all types of ICU patients. There's a medical ICU which manages patients with medical conditions not secondary to surgery. So for instance, renal failure, diabetes, neurologic disease would be handled in a medical ICU. There's surgical ICU, which manages patients who are very sick and who have had or will need surgery. They may be come after surgery or actually being prepared for surgery. There's cardiac surgical ICUs, which usually are managed by cardiac anesthesiologists and care for patients after open heart surgery. There are neurologic intensive care units primarily for patients with head injuries or serious neurologic conditions, which are handled primarily by neurosurgeons and intensivists or neurosurgeons and neurologists. There are trauma ICUs for patients with life-threatening injuries following trauma, and these are usually handled by either trauma surgeons and intensivists in partnership. And finally, there are coronary care units for patients with ischemic heart disease, which are usually managed by cardiologists. In addition, one that I haven't put on the slide, but one that is often considered an ICU is the post-anesthesia care unit, the PACU, which I discussed in an earlier lecture. So the ICU physician, the intensivist, the training for intensivists varies in different countries. And in rural communities, it's usually an anesthesiologist who takes on this role. In my country, Canada, there is a three-pronged approach to intensive care medicine qualifications. One must complete either their anesthesiology training, their internal medicine training, their general surgical training, or their emergency medicine training before applying for an intensive care residency. This is a further 2 years of training in which they learn how to deal with all kinds of ICU patients. This varies from country to country how this is managed, but in Canada it takes, on average, 7 years to 9 years after completion of medical school before one completes their intensive care residency and is classified as an intensivist. So what happens to a patient that enters the ICU? Well, the first thing that happens is they have a very complete physical exam, much more complete than we see in most areas in the hospital, but it's done quickly and with great efficiency. It's a head-to-toe assessment with special focus on gross neurologic exam and the level of consciousness. It's very important to know what your patient's level of consciousness is at the beginning of their stay in the ICU and to keep an eye on that throughout their stay. There's obviously a pulmonary exam with emphasis on ruling out pneumothorax and observing the respiratory pattern of breathing, determining whether the patient may have pneumonia or some other major problem with ventilation. There's a cardiovascular assessment with emphasis on the patient's volume status. This is often included with a cardiac ultrasound, transthoracic ultrasound done through the chest wall, and assessment of central venous pressure, which can be done by reading the jugular veins on the side of the neck, or by placing a catheter in the jugular vein down into the heart and actually measuring the pressures. There's a daily abdominal exam, and there may be ultrasound done on the abdomen as well, and a careful assessment of bowel function on a daily basis. There's almost a continuous assessment of skin lesions, swelling, edema, and a focused exam on areas of greatest concern. So the admitting examination by the intensivist takes about 30 minutes. But every day there's a follow-up examination by the intensivist that takes between 5 and 7 minutes. The ICU nurse is also a highly qualified healthcare provider. A critical care nurse has to complete nursing training and work for a number of years as a general duty nurse or a subspecialist nurse in a place like the emergency or the operating room before they attempt to qualify as a critical care nurse. They must show the ability to assess patients, react quickly to changing conditions, make decisions quickly, and know how to manage many highly potent drugs, dangerous drugs, and operate complex equipment. It's often up to the nurses to manage the patient's changing condition for some time before a physician becomes available. So nursing aspects of care include a complete reevaluation of the patient at each change of shift. So that can be 2 or 3 times a day. The ability to infuse very potent drugs safely, and they have to spend a significant length of time learning how to do this. They learn constant assessment of hemodynamics and how to adjust the drugs as necessary to maintain as stable a hemodynamic situation as possible. They provide a constant assessment of ventilation. They have to know how to manage transducers. There's a constant assessment of the level of consciousness. There has to be management of sedation, pain, and muscle relaxation. They may have to manage continuous renal dialysis, and they may have to manage end-of-life care. They are the ones who provide most of the communication to the patient and family in collaboration with the physician, but the nurse's role is vital in all of this. So let's talk about some fairly common diagnoses in the intensive care unit. So infection is a major reason to admit patients to the ICU. Failing organ systems is a second reason for admitting patients: heart failure, renal failure, respiratory failure, and medical conditions with high mortality, such as vasculitis, overdoses, toxic syndromes. Patients in need for ventilation: respiratory failure, pulmonary edema, closed head injuries, diabetic ketoacidosis, renal failure again, and other major system disease. SIRS, which we'll talk about briefly in a moment, is systemic inflammatory response syndrome and requires intensive care treatment. And anytime a patient requires complex equipment, such as a ventilator, or a left ventricular assist or right ventricular assist device, which we'll talk about in a minute, continuous renal dialysis, or as it's more properly called, continuous renal replacement therapy, CRRT, or extracorporeal membrane oxygenation, ECMO. So the modern ICU ventilator is a highly sophisticated piece of equipment which can deliver different modes of ventilation according to the patient's needs. It tends to be a little higher quality than the ones we use in the operating room, although that's changing. The ones we're using in the operating room are increasingly being used for critical care patients who are transferred from the ICU to the OR, so we basically need the same equipment in both places. Volume-controlled ventilation is the commonest mode of ventilation control, in which we set the volume and the minute ventilation or the ventilatory rate that we want the patient to receive, And we usually adjust this according to the patient's arterial oxygen saturation and carbon dioxide levels. And we can do either blood gases, or we can do end-tidal CO2, or just use saturation continuously on these patients. Pressure-controlled ventilation is used for patients with high airway pressures who are at risk of barotrauma or damage to the lungs from high pressure. From volume-controlled ventilation. And in this situation, instead of setting the volume, the maximum inspiratory pressure is set, and the ventilator rate is set according to blood gases or saturations or end-tidal CO2. Pressure-assisted ventilation is a situation in which the ventilator assists the patient's own ventilatory efforts by providing a boost in pressure with each breath to assure adequate ventilation. So the ventilator can sense when a patient is trying to breathe and quickly intervene to make sure that they get a breath and that they get an adequate breath. We can easily add positive end expiratory pressure, which is basically applying pressure that is maintained in the lungs even at end expiration. So normally when you expire fully, there's very little pressure in your lungs, but when we're healthy, there's still a lot of gas in our lungs that continue to supply oxygenation to the body. In sick people, that can be a problem. So PEEP is added, usually in fairly low levels, just to maintain lung volume in sick people so oxygenation is supported. If ventilation is prolonged and the patient cannot be weaned, tracheostomy is often provided, and the patient may be ventilated through their tracheostomy, or in a better situation, they start to breathe spontaneously through their tracheostomy. Other organ systems are also extremely important, such as kidney, and renal failure in the ICU is now treated primarily with continuous renal replacement therapy, or CRRT. The reason this is used is its slow, gradual technique rather than the more rapid, dynamically dramatic changes that occur with hemodialysis. So when you put a person on hemodialysis, you tend to push their blood pressure down, their volumes change very rapidly, and normally people can tolerate that, but they can't when they're critically ill. So continuous renal replacement therapy has replaced that. Acute lung injury, or ALI, used to be called ARDS, or Adult Respiratory Distress Syndrome, and has been revolutionized, the treatment of this disorder, by changes in ventilatory mode that have only been introduced in the last 5 years or so. And these have included using much smaller tidal volumes than we used to, and more rapid respiratory rates, thus creating good minute ventilations, but low pressures in the lungs. This has reduced ventilator-associated lung trauma dramatically and has improved outcomes. ECMO, or extracorporeal membrane oxygenation, is used more frequently and more effectively than it once was, and we'll talk about this in a minute. Cardiac failure, we work on by using left ventricular cardiac assist devices at a much earlier state than we used to. And these devices, and we'll discuss this in more detail in a moment, can act as a bridge to heart transplant, or more appropriately, as a treatment from which the patient will recover from their heart failure and the left ventricular assist device can be removed. So infection that is often difficult to treat is a very common problem in the ICU. And ventilatory-associated pneumonia, VAP, is a common problem. And intensive care units now use what's known as a VAP pack, which reduces the incidence of VAP and improves the treatment of VAP.